It's a great pleasure for me to have here Nancy McWilliams, renowned psychoanalyst, professor, and author of Psychoanalytic Diagnosis and PDA and other very good works. So it's very nice to meet you.
Thank you.
And thank you for wanting to talk to us and for being open for the dialogue. The very first thing I wanted to ask is just generally, how did you become interested in psychoanalysis?
Oh, I was a political science major and political theory in general. And in my junior year, my faculty advisor said to me, you might consider for your honors thesis, because you're a psychological kind of person, to write about the implicit political theory of Sigmund Freud. And he handed me the book Civilization and Its Discontents. And I read that, and it was very simpatico. I felt it was fascinating. And I began reading more psychoanalytic writing, especially the work of Theodor Reich, who was writing books for a more popular audience at the time. And he was the first writer I'd ever read who talked about the psychology of women in a way that didn't make female psychology a kind of strange exception to the norm of male psychology. So the whole idea that there was a respectful interest in women's psychology appealed to me too. Then I fell in love with my faculty advisor and married him.
Wow.
And decided I would get out of his field, which was political theory. And by this time, I felt that my temperament was better suited to being a therapist than a full-time academic, and that I could read all this fascinating writing about the unconscious. I also, my own personal psychology is somewhat Freudian. I'm very Oedipally organized. I have somewhat hysterical tendencies in terms of my internal dynamics. And so Freud captured a lot of things that I resonated to. And I was living in New York right after I graduated from college, and Theodor Reich was still alive, so I went to see him.
Okay.
I wanted to meet somebody who'd been personally close to Freud, and there were very few left.
How old is he?
He was in his late 80s. And he told me if I was going to go into the field of trying to help people, I should be analyzed. And I thought, well, I'm in New York. I don't know for how long. I can still get inexpensive psychoanalysis here at the institutes. And he sent me to the institute that he had started. And I just took the analyst they assigned me, which now horrifies me, but it turned out to be a very good match.
Okay.
And I think it was my own psychoanalysis being so unexpectedly therapeutic to me. I had viewed it as kind of an intellectual exercise to go through.
You were not
analysis.
looking to get therapy, you were trying to develop.
Well, I think unconsciously I was, but I didn't know that.
Yeah.
Unconsciously, I think I knew I needed therapy. Consciously, I thought, well, this is just the obvious thing to do. It's like taking classical piano before popular music, or studying Latin and Greek before French and Spanish. But it helped me enormously. And then I went, once I got enough undergraduate courses in psychology to qualify me to take a graduate program. And my husband took a job at Rutgers University. The Rutgers University program in personality had some psychoanalytically friendly people in it, Sylvan Tompkins, and then later George Atwood and Robert Stollerow.
Okay.
And it was a very comfortable place to learn about depth approaches to personality issues, because I've always been just very fascinated by individual differences.
Well, as to psychodynamic concept of personality, because we talked before about the difference between trait approach and theme approach to personality.
Yeah.
Could you elaborate a little bit on that?
Well, yeah, there's a tendency currently to try to reduce personality to traits because they're easily measurable, and we have a wonderful, extensive literature on traits that distinguishes among people, the so-called big five traits, for example. The problem for a therapist is that the clinically important personality differences are not the differences of those traits. And in fact, talking about people in terms of traits at all doesn't capture something very important. If you're trying to describe obsessive-compulsive people, for example, it's true that they have the trait of neatness, but they also tend to have some part of their life that's a terrible mess. And they're better conceptualized as people who are organized around the theme of neatness versus messiness, control versus discontrol. Schizoid people are better described as struggling with closeness and distance, not just having the trait of tending to distance themselves. Hysterical people can be both inhibited and sexually promiscuous, because they're organized around issues of gender and sexuality and power. Paranoid people are distrusting and suspicious, as the DSM would say, in terms of traits. But they can also be pathologically over-trusting, like people who believe that Hitler or Stalin is flawless and have a paranoid attitude toward anybody who's not in their group. So it's better to describe people with a paranoid sensibility as being organized around the theme of trust and distrust rather than the trait of distrust. So those themes have emerged from clinical experience, and there's also a lot of good research on the kinds of ways in which people are unconsciously organized around an interpersonal theme. So the difference between an obsessive person and a schizoid person, a hysterical person and a paranoid person, isn't really captured by traits. It's, the obsessive person would be somewhat indifferent to the gender issues that preoccupy hysterical people, or the trust-distrust issues of the paranoid person. It's not that one is neat and one is not. So that's my objection to trying to think entirely in terms of traits, even if, as the DSM-V is proposing, you're developing a more dimensional view of traits, whether you're high or low on something. It's hard to assess where people are high and low when they've got the whole contradiction in their personality. Narcissistic people are organized around the theme of inferiority versus superiority, for example. And so on a self-esteem scale, would you say they're high or low? They're both. They're defended against feelings of inferiority.
So was this type of thinking the driving force behind development of PDM, Psychodynamic Diagnostic Manual?
It was part of the drive. The feeling about the PDM was not just about the DSM problems in conceptualizing personality, but in many kinds of suffering. There was not attention to the internal subjective experience of the patient. And that applies to some symptomatic issues too, like for example with anxiety. Since the DSM decided to go categorical and descriptive instead of inferential and dimensional, anxiety is described as rapid heartbeat, sweaty palms, the report of the experience of anxiety. But we've learned in clinical experience that there's a huge difference between, for example, annihilation anxiety and separation anxiety. And even neuropsychologically now, we understand that different brain systems are activated in those. One is a kind of residue of our fear of being objects of a predator, and it's not mediated by serotonin, that kind of anxiety. It's not comforted by talking to a patient about the need for a relationship. Whereas separation anxiety is mediated by serotonin, and it's in a different part of the brain. And the people who decided to organize the PDM were feeling that a lot of clinical knowledge was being lost, even clinical knowledge on which there was a huge amount of research, because of a certain paradigm that looked only at externally observable, present versus absent criteria of describing something.
Okay. There's this book by Randall Sorensen that is called Minding Spirituality. So alluding to that, I want to ask you, do you and how do you mind spirituality in your practice?
Well, I define spirituality broadly, and I find that if people are encouraged to talk about their spirituality, much richer data comes into the clinical experience. Mostly with patients, I try to encourage an atmosphere of safety in which they can talk about what's most intimate to them. And I find their spiritual feelings are sometimes much more intimate than their sexual practices or their attitude toward money or some of the other things that people are reluctant to talk to someone about. And if you make a space that welcomes their sense of awe and wonder and dependency on a power larger than themselves, attunedness to the more invisible aspects in the universe, most people are able to tell you much more important things about themselves.
Are people not afraid of being reductive or of being reduced in their spiritual aspect in psychoanalysis? Because that's the general feeling or the general maybe misconception that psychoanalysis would reduce spirituality to something else.
Yes, some patients are afraid of that, especially if they haven't read much psychoanalytic writing and they know mostly about it in terms of people's application of a bias that Freud had. Freud was very frightened that psychoanalysis would be perceived not as a science, but as a Jewish cult. And so he put such emphasis on the logical positivistic basis of it. And he personally was agnostic, although his sensibility was deeply Jewish and influenced by his religious tradition. And he tended to view people who were people of deep belief as non-scientific and pursuing an illusion. That was Freud's particular bias, but that didn't define the later psychoanalytic movement. So yes, I think some people are afraid that they will be reduced to, magical thinkers.
Yeah. Would you say that there is a growing openness to spiritual issues in psychoanalysis in these days?
Yes, absolutely. In some quarters there always has been, and to some extent that was true even in Freud's time. Freud was close to a number of theologians, including, for example, James Jackson Putnam, an American thinker, and many others that I know you know the work of Murray Hoffman that she has written about. But especially now, with the relational movement in the United States and with other movements in other countries that in which clinical experiences that people need to talk about their spiritual dimensions, there's much more interest in that aspect, much more respect for the complexity of that part of life.
Would you say you are a spiritual person?
Yes, although I'm not a particularly religiously observant person, but I think I've also always had a sense of wonder and a sense of my dependency on some power that's greater than myself. I also was very influenced by my own religious training, which was in mainstream Protestant churches. And a lot of the first ways that I tried to understand human behavior was in the language of religious thinking. I was very influenced intellectually by a book by Robert Lovinger that was published in the 80s called Working with Religious Differences in Therapy, where he made the argument that many people view religious thinking as somehow childish, and I think Freud falls into that category. And he argued that the reason is that most people's religious training ends when they're about 12, and the categories in which you can teach about religion before people are 12 years old are childish categories. But the great religions have all dealt with the great human issues, and they've all written about central psychological struggles that people have. And if you stay with a religious education beyond the age of 12, you get into the age where sin becomes more real to you. then the great religious thinkers all are very astute about things that we can write about in psychoanalytic language, but there are older languages for describing the same things.
Interesting. How do you, as a person who comes from the, you said, Protestant background, how do you find psychoanalysis compelling as a person from Protestant context?
I think it was very appealing to a kind of Christian sensibility that I have that has something to do with how much we don't know and appreciating how much we don't know. It's hard for me to talk about this without talking about it in terms of the interaction with my own idiosyncratic history. I lost my mother at 9 to cancer, and I think for me, one of the things that I learned in that loss was it was a kind of traumatic and developmentally a little bit premature loss of a sense of omnipotence. And I went for comfort to the Bible and thought a lot about the sin of pride, and which I understand to be the human tendency to believe that we're in control of a lot more than we actually are in control of. I was very comforted by Jesus's words, especially the Sermon on the Mount, when I was suffering. And I guess I felt when I started discovering psychoanalytic thinking that it was another language for talking about what happens to our omnipotence as we grow up, how differently our conscious thoughts can describe something from how our unconscious experience sculpts it. And the general Christian emphasis in the direction of humility made a deeper intellectual sense to me as I realized how much is unconscious. I also think I thought a lot about my Christian sensibility when I was in psychoanalytic training, because most of the analysts I was training with were Jewish. It was in New York. My analyst was Jewish. There was a certain Jewish sensibility that I was attracted to. I think Protestants tends to see themselves as reverting toward the Old Testament. And so I was interested in Judaism. And I noticed that my own temperament had a lot of Protestant tendencies. Protestants tend to like to try to find the good and be very clear about what is good behavior. And you can, you're sinful, you're never going to be able to atone for it. It's just who you are. And so I was struggling to be good. And it was very healing for me to be in the presence of a person with a kind of rabbinic sensibility of, on the one hand, there's this, on the other, there's this. You know, you can't be so sure. That was very corrective to a certain kind of Protestant self-righteousness that I inclined toward. So I felt that religious difference in a way that perhaps a Jewish person in psychoanalysis would not have felt, because they wouldn't have been in a conversation that was culturally a little different from what they were used to.
Yeah, so where would you see the potential for dialogue, or maybe also for tension between mainstream Christianity and psychoanalytic sensibility?
You know, as a person who's not that well versed in theology, I feel a little out of my depth to be asked that. But I think there's a lot of room for dialogue. I do think there are some areas where there are tensions. For example, I'm not sure this is an accurate version of Roman Catholicism, but some of my patients who are brought up Catholic, for example, are very concerned that they have impure thoughts. And I think the psychoanalytic attitude is that everybody's got impure thoughts, and how you should judge yours not. You shouldn't be trying to purify your thoughts. You should be aware of them and being very careful that they don't govern your actions if they're impure. And even in individual therapy, I have sometimes had to articulate with a patient the tension between their hope that I can make them internally pure and the reality from my perspective that that's not a realistic expectation. So I do feel in clinical practice both the tension between some beliefs and also the tremendous room for comparing some of the areas in which there's profound overlap.
Is there anything specific you find about Christian psychological audiences? I know you gave a keynote speech at a CAPS meeting some time ago. So is there anything that strikes you as specific to these type of people?
It's hard for me to talk about that intellectually. I know that I feel at home with people who come from that sensibility. I resonate to their wish to be good and to be respectful and to walk in another person's shoes. To me, that was one of the main messages of Jesus that I resonated to, that, you know, don't criticize other people until you've looked at your own flaws, and try to understand that if you know their story, they are an equal human being. I see Christian audiences as particularly organized around that attitude. There's a certain kind of Christian guilt that feels to me a little bit different from Jewish guilt, for example. Jewish guilt, and this is one of the points that Lovinger made in his book that I just mentioned, is often around the preservation of the community. It's often around the guilt-provoking messages that my Jewish friends have gotten tend to be, you know, you're not taking care of your family enough, you're separating too far from your mother, and the guilt of Christians is not so much about preserving a community, I think, as it is, especially in Protestants, standing for what's right, you know, standing alone. It's almost the opposite. I will find myself feeling guilty if I have a disagreement with somebody and I find myself not saying it because it's uncomfortable. I haven't stood alone enough, like Martin Luther nailing the thesis to the door, you know? That's a different kind of psychology, and I think in Christian audiences, at least the Protestant elements of them, there's a lot of concern with, am I being true? Am I being honest? Am I being fully moral, individually? So I sense that part of the atmosphere in a group like the CAPS group that you mentioned. I also find that Christian audiences are highly, especially pastoral counselors, are the best educated in a broad way of all the people that I'm ever asked to do training for.
You mean what type of education?
Well, this is my bias now. I think I agree with Freud in his writing about so-called lay analysis, that the best preparation to be a psychoanalytic therapist is not to be a physician or even a psychologist, but to be somebody with the broadest possible education in the humanistic traditions, the social sciences, the sciences, And some of my graduate students in psychology, for example, are very well trained but narrowly trained in a certain kind of empirical approach to understanding people, but they haven't been given the immersion in the great theorists of human behavior, including religious theorists like Aquinas or Augustine. And they lack the kind of breadth in the humanities, the arts, the sciences, the social sciences, that I think makes one a better therapist, because the more rich your own education is, the more you can find the elements in which you can resonate to the patient's.
In a way, you're coming to my next question, which is whether you think that psychodynamic concepts might be useful to a more general public, or whether it is some knowledge that should be treasured only for and by experts.
Oh, I'm allergic to the idea that it should be treasured only by experts. I think it's very valuable for people to know these things, and I've spent my career trying to make psychoanalytic ideas more user-friendly, because they've been so helpful to me. I think they're helpful to my children. I remember my mother, who, as you know, not having known her as an older person, I don't really know what her own education was, but she used to tell me when I was a little girl about people's psychology, and it helped. For example, I remember if I was upset because a friend had been nasty to me, she would first try to comfort me and respond to my pain, and then she would say something like, "I wonder why she did that to you. Do you suppose maybe she's envious of certain aspects?" So she taught me to mentalize, really, and taught me to think about the subjectivity of the other person. And to whatever extent we can increase people's capacity to understand the subjective experiences of other people, I think we should be giving them help doing that. So I think it's a perversion of the psychoanalytic tradition to try to keep it among certain professionals. Freud wrote for a lay public, and so did some of the better analytic writers. But once psychoanalysis got kind of medicalized and conventionalized in the middle of the last century, there was a tendency for some analysts to act as if they had some very special, precious jargon that other people weren't somehow good enough to share. And I've always found that offensive.
Yeah, because some people find it dangerous to give these concepts to people who might misuse them or not use them in a trained enough way.
Well,
you know.
people can misuse anything, though. Look what they've done with Jesus, or Allah, or Muhammad, or Marx.
Yeah.
You can pervert any message. That doesn't mean you shouldn't try to convey what you think is valuable.
Okay, so what do you think is the place of theory or the relationship between theory and practice in psychotherapy?
I think we all have implicit theories, and if we try to be atheoretical, we're kidding ourselves. So the question for me is, I like to expose people to as many theories as possible so that they can find language that is relevant to their current clinical challenge and the current patient that they have.
Well,
So,
in your writing, you're very integrative. So what is it what helped you to not see strife between different approaches, but to see what helped you to integrate to such an extent?
I think part of it is temperamental. Darwin said we're all either lumpers or splitters. We tend to see the communality among things or to make distinctions. I think most therapists have a lumping kind of mentality. We will learn from anybody who will help us to help a patient. So some of it is temperamental, and I would say some of it is somewhat gender related. There's some evidence that women tend to think more that way, and men tend to take more the distinction-making role. But in terms of my clinical experience, I just found that I had some patients who made one theorist look really good, and other theorists wouldn't touch what was important to that patient. So if I didn't know Kohut, I wasn't able to understand certain features of narcissistic suffering. But Kohut wasn't that valuable to me in understanding post-traumatic suffering, for example. I think he could be adapted, but there are other people who captured that better. So I've always wanted to treat a range of patients. I don't do just psychoanalysis. I would be a bad teacher if I weren't working with the range of people that my students are working with. So I've always worked with people of a range of psychopathologies, of a different level, of psychotic, borderline and neurotic level people, people of different backgrounds, socioeconomically, culturally, and so forth, in terms of their sexual orientation. So the more diverse my practice is, the more I have to draw on a whole range of different angles of vision.
Yeah, not being bothered by theoretical purism.
Yes, yes. I think when people start out in my field, they tend to like to have one theory because the data are so overwhelming sitting with any person. You want to fit them into some way of understanding them. But as Roy Schaefer pointed out, the longer you do the work, the more each orientation within psychoanalysis expands to include the other aspects. So Freud and Jung differed a lot about things, but I think most psychoanalysts have integrated both Freud and Jung and feel that Jung captures some things better than Freud did, and vice versa.
Yeah. How do you see the latest theoretical developments in relational psychoanalysis? Do you see it as relativizing the things that were incurrent before, or do you see it as something that is an addition or a new perspective on the old type of thinking? Just what is your take on relational approach?
I think the relational approach has been very enriching to the psychoanalytic field, and it has corrected for some of the perversions of the ego psychology movement. I think it can be itself perverted into a level of relativism that can be problematic. And some relational thinkers are so worried that they are going to be too essentializing that they're not teaching some elements of psychoanalysis that I think would be very helpful to students. So sometimes I feel a certain tension with some elements of the relational community, but overall, I think it's been a kind of democratizing movement in psychoanalysis, which we badly needed. And the emphasis in the relational movement on not knowing. I guess the theme in this, if I'm hearing my own answers to your questions with my own third ear, is about humility, that we don't know. We are not in the position of the person who already knows what's important in what you say. Yeah. And this was a contribution of Theodore Reich's too. We try to put ourselves into a discourse that allows us to be surprised. Donald Stern talks about courting surprise, letting the patient teach you. And that sensibility has been a profoundly important corrective to the earlier sensibility. I think there are good and bad relational practitioners, just as there were good and bad ego psychology practitioners, good and bad object relational practitioners, Kleinians, and so forth. When people get formulaic, when they're intellectually lazy, and they do it in the name of their orientation, it's a problem. But I don't think it's a problem with the orientation itself.
About how it is done. You also started to talk lately about mental health from psychodynamic perspective. How did you come to this thinking, and why this stress? Why this is something that would capture your attention?
Ever since the DSM was revised in 1980, in the direction of describing externally observable present versus absent symptoms, instead of having a diagnostic manual that captured range and inference and complexity, I've been concerned that we are starting to define improvement in psychotherapy based on symptom relief. And that's not even a good medical model, you know. A good doctor doesn't define cure as getting rid of a rash or a fever. But especially in the United States, we're under pressure from drug companies and insurance companies. We've got a lot of background music that might be a problem here. But drug companies, insurance companies want to define things as the reduction of a symptom because their drug can handle that, or that will take few sessions. But I think what inspired me to work on this now was I was going around teaching about the Psychodynamic Diagnostic Manual, and I said that the DSM has no real concept of mental health, except the GAF scale, which is kind of, you know, it's all external, like can you hold a job? And then I would list a whole lot of things that psychotherapists have traditionally looked at as part of, you know, maturation, sanity, wellness, like whether you can love and work and play, whether you have object and self-constancy, whether you have realistic and reliable self-esteem, whether you're resilient and have ego strength, whether you have an observing ego or the capacity for insight into yourself, whether you can mentalize other people, whether you have a sense of humor, whether you can accept what can't be changed. And I would list a whole lot of stuff like I just did, and I'd see people wildly writing them down. And people would sometimes tell me afterward, that was a great list, I've never heard that before. And I realized that in the 70s, when I came of age as a practitioner, there was a lively conversation going on in my culture about what is mental health. Are we trying to adapt people to a sick society? We had Maslow's hierarchy of needs. We had Marie Jahoda's work. We had the anti-psychiatry movement. And I was struck that we weren't having that conversation anymore. And I started worrying that we've seen a paradigm shift away from therapists understanding therapy as a healing relationship and seeing themselves as healing presences, toward defining therapists as technicians on behalf of the larger society who are just supposed to shape people up until their behavior is not inconvenient to the larger society. And I think that's a very sinister drift. So I've gotten interested in specifying what the clinical tradition, and I would say this meshes with a lot of the older theological thinking about what is the good life, what it says about what not just makes people happy. I mean, we have the positive psychology movement, and that's talked a lot about happiness, but what is of value to people? I would say that mental health involves the capacity to tolerate certain kinds of unhappiness and suffering, for example. So I wanted to get that clinical knowledge organized and out there more, because I think it's in danger of being lost.
Yeah, many people would be surprised that this comes out of psychoanalytic thinking, because people tend to see psychoanalysis as hung on the negative, on pointing out what's not working, what's dysfunctional, and so on. So I see this as a very good corrective to the general perception of analysis.
Yes, you know, it's a shame that analysis has drifted in that direction itself. Because I think one of the things I do admire about Freud is that he didn't write about himself as the healthy exception, looking at the sick other, so much as talk about how we all have neurosis. And he wrote about savages, you know, which at this point reads as a very racist kind of attitude. But what he was trying to say was, in contemporary civilized cultures, we're still struggling with the same thing that people that we think of as primitive are struggling with, and here's how it shows itself in our culture. So he was trying to express a kind of egalitarian sensibility. We all suffer, we're all crazy, we're all broken, and we can help each other with that. So it would be nice to reinstate that attitude, as opposed to there are some experts who are mentally healthy and they will cure those unfortunates who are different.
how do you see the relationship between psychoanalysis and other therapeutic approaches? Do you think there is a rivalry or exclusion, or you think there is a possibility for communication?
Both. There's certainly some central differences between psychoanalytic ways of working and biopsychiatry or certain cognitive behavioral assumptions, some broadly humanistic assumptions. But for years we've known that therapists who are experienced work a lot more similarly to therapists of other orientations than they do to beginners in their own orientation. So there's a certain kind of way in which experienced therapists will come to the same conclusions, but in the language of their orientation. One of my reasons for finding the psychoanalytic orientation particularly rich, it's the longest one, so it's elaborated more about the experience internally. But I see the cognitive behavioral movement going in that direction in the work of Marshall Linehan, for example, or Jeffrey Young, or Jacqueline Persons. So, I think there's plenty of room for talking across orientations. I also think some of the other movements, like movements toward developing therapies for particular symptoms, like exposure for phobic symptoms or OCD symptoms, I think those are extremely useful and can be integrated with a psychoanalytic approach. I also have people coming to me who have been trained in those approaches who say to me, those are insufficient for what my patients are asking me for, and I need a psychoanalytic sensibility to understand personality dynamics because I wasn't trained in those. I think we're very lucky to have some of the medicines we have now, but I think if you think that all you're going to do for people is correct them pharmaceutically, you're missing a tremendous amount of opportunity to help them. And most psychiatrists that I talk to these days are feeling that they'd like to know more about the depth psychology approaches. Because even if they're just trying to get people to take their medicine, they're running into things we've talked about in the psychoanalytic tradition, like unconscious resistance, and the importance of the relationship in helping people push past unconscious resistance. So even if you're just trying to get your patient to take a pill, it helps to understand what their transference to you might be, why they might resist what you're urging them to do. Maybe they see you as a parent who's trying to poison them. So I think there are tensions, but there's a lot of room for conversation among people of different orientations.
When I come back to the idea of diagnosing people, do you think diagnosis is something that can usefully be done at the beginning of a treatment, or it's something that is developing throughout all the work with the patient?
Both. I think at the beginning of treatment, it's important to get a sort of general diagnostic formulation. Some very practical things hinge on it. Is the person suffering from brain damage, or do they have, personality disorder? The treatment is quite different. Do they have a bipolar illness versus are they borderline, in which case the treatment is different. So certain general kinds of diagnosis are very important to try to do early. But as Anna Freud said, psychotherapy ends, diagnosis never does. Because the longer you work with somebody, the more complicated they turn out to be, the more they tell you things they weren't willing to tell you or able to tell you in the beginning. So your diagnostic formulation, you don't need it by the end because you know this individual person. But if you had to describe the person, at the end of therapy, you can diagnose them a lot better than you can at the beginning of therapy. So both.
I had another question. Yeah, some people talk about psychotherapy as a lifestyle. I've read somewhere an article on psychotherapy as a lifestyle. Do you think psychoanalysis is or can become a lifestyle?
I hope not. Although, I guess I'm trying to think about that statement in a positive and a negative way as you ask me. I find it offensive when analysts behave as if they're in the consulting room when they're not, when they have the conceit that they can understand people better than the next guy can understand them, because psychoanalytic understanding is based on a particular setting in which we invite people to say everything, which people don't do in social settings. So behaving like an analyst outside the analytic office, I think, is an affront to people. So that's the negative side. In terms of a positive side, I think who I am as a person is so indistinguishable from my psychoanalytic understanding of life that I do think I'm the same person in every situation. I don't switch into a different or a radically different version of myself when I'm in a different role. And I do think the values that infuse the psychoanalytic tradition infuse my life outside that tradition. So, it depends on which way I'm understanding the meaning of the question, how I would answer it.
Okay. Maybe one of the last questions. You wrote several very valuable books. Is there anything that you're planning on, either as far as writing a book or as to next step in your work generally? Where are you heading now?
I am working on a book on overall mental health, and for the first time, I'd like the intended audience to be a more general audience, not an audience of therapists. So it's my first venture into what they call a trade book. I may be co-authoring it with my daughter, who is a political scientist like her father, a political theorist, who would be viewing through a macro lens the things I'm talking about from a micro lens. So that project will take me a couple more years. But I think I can probably predict that I will still find myself writing about individual differences for the clinical literature, because what I get interested in depends on who has walked into my office and what I'm struggling to understand. So I've written about paranoid personality, about schizoid personality, about masochistic personality, about what it's like to be a heterosexual person treating somebody who is lesbian or gay or transgender or bisexual. So it depends on who I'm working with, what I start reading about and wanting to integrate myself. So I can probably predict that I will be working with somebody that will stimulate my interest in writing about that. I have a couple of Hindu patients now. I'm learning something about Hinduism through them. One not observant, one quite observant. And so that interests me, how my sensibility both misperceives some things or can be educated by their different angle of vision. I may end up writing about that. I will probably also always be writing about individual differences.
How many patients do you have at a time?
Oh, usually I like a small caseload because I like to work long-term and in-depth. Usually I have about 15 people at any given time.
So you meet 15 people on a weekly basis? Or?
Some are much less. Some, have seen me for a while and are cut down to every other week or even once a month. I have a couple at twice a week, one at 3 times a week. And I do a fair amount of supervision too. Maybe I've estimated that a little high at 15, but if you do include the people who come more occasionally, it's about 15 that I'm thinking about at any given time.
Okay, and my last question, what has surprised you the most about the reception of your work in the world? I know you travel a lot, you talk to people a lot. Has there been anything that has surprised you by how people perceive what you speak and write about?
Well, the enthusiastic international reception came as a complete surprise to me. I did expect that the book would do well in the United States, because the reason I wrote it was that I got sick of hearing myself complain that there should be a book like this. I kept waiting for McKinnon and Michaels to rewrite their book. And my students got sick of hearing me complain, and they started saying to me, "You've got it organized. Why don't you write it? It would be very useful." And my department chair started saying that. So I wrote it knowing that people would be happy for this kind of book. But I didn't expect that in quite different cultures they would find it so useful. It's been translated into languages such as Korean, Turkish. There's an effort to translate it into Farsi and Arabic, I think, at this point. Polish, Italian, Greek, Portuguese, Chinese, Japanese, some very different cultures from my own. And what the therapists there tell me is they recognize all those kinds of personality. They are in different proportions in their cultures, but they recognize them. And I have found it absolutely fascinating to go to other countries and have them tell me what is the most common kind of personality disorder in their country. It's been fascinating. The Russians told me they felt that masochism was their national character. Italians told me they thought theirs was hysterical. Swedes told me they thought theirs was schizoid.
I would say all are right.
In Australia, they told me theirs was counter-dependent. In South Africa, they told me they felt they were paranoid. In Greece, they told me they thought they were paranoid. In Polish, they told me they were post-traumatic. In Singapore, they told me they were obsessive-compulsive. In China, they told me they were dependent. When I ask them what they think of Americans, they look a little bit nervous and they say narcissistic, which is accurate. So there's been this rich conversation about individual differences and how they interact with cultural differences that I was completely surprised by. And I never expected to enjoy my career in this large a scale.
So thank you very much. It's been very pleasurable to talk to you, and have a nice time in Prague.
Thank you. I expect